Jimmy Dura, host of All Things Veterinary, a podcast that connects and unites the animal health community with ideas and innovation, topics to inspire you and energize your day. And today we have an extra special episode, and we're excited to be joined by our guest, Darci Palmer, to continue our discussion on one of our most popular and important topics, anesthesia. Today we're broadcasting from Tuskegee University College of Veterinary Medicine. And our guest today, Darci, is a Veterinary Technician Specialist in Anesthesia and Analgesia at Tuskegee University. She is the Executive Secretary at the Academy of Veterinary Technicians in Anesthesia and Analgesia, and she is one of the administrators of the Veterinary Anesthesia Nerds Group, who are elevating the standard of care for veterinary anesthesia. Darci, it's a pleasure to have you on. So excited to have you here. And if you'll just tell us a little bit about yourself and your background and what drew you to anesthesia.
Well, thank you so much for having me. Okay, so about my background, I have always been drawn to the profession of veterinary medicine, and I'll be honest, I did not actually even know that the veterinary technician career field existed.
Really?
It was one of those things that I kind of fell into, actually. In high school, I just decided to go volunteer at a vet clinic, and that's really what drew me to the profession. But I knew that I wanted to go to college, so I went and got a college degree and then ended up and came back and worked for that same veterinarian that I had been with all through high school. And then he was the one that actually encouraged me to pursue getting or taking the national board exam for veterinary technicians. So he helped me do that. So after I graduated college, I lived in a state where grandfathering was acceptable way back at that time. So we did all the paperwork, and then I sat and took the VTNE and passed it and became a credentialed veterinary technician in 2000. So my goodness, it's been 24 years.
Nice.
But I've kept that up, and then my main background was always in equine, and I really liked the horses. In fact, I was headed towards a career in equine reproduction, but I met a boy, and that boy wanted to go to vet school, and so I ended up following him back to Washington State University, where I got my undergrad degree there. And then I just applied, and there was a position opened in anesthesia, and they were desperate to have credentialed vet techs come there. And so I took a chance and decided to try it out, and I ended up falling in love with the specialty. And I 100% credit that to the fact that I worked with anesthesiologists who really fostered that relationship between doctor and veterinary technician. They saw the immense benefit of having their technicians trained well enough so that we could be their extensions to their eyes and their ears and their hands. And it was just a wonderful experience to work with anesthesiologists who really fostered that relationship. I mean, they took us under their wings and did regular round sessions for us. And it was actually one of those anesthesiologists who introduced me to the veterinary technician specialty credential. And so they were the ones who really helped us want to pursue getting specialized when that became a thing way back when as well. Yeah, so that the whole draw to anesthesia really kind of fell into my lap. I never really saw myself working in anesthesia. In fact, anesthesia scared the crap out of me when I first started in it, but it was that love and training of those anesthesiologists that really took us under their wings and showed us what a great specialty it is. And now I can't see myself doing anything else.
That is really neat. And that story, I think, is probably similar for a lot of us. You just you find this industry, or the industry may find you.
Absolutely. Absolutely. You find your little niche.
Yeah.
And then that's where you really, now, like, you talk to me about microscope work, I'm like, no thanks. Dentals, no thanks.
Yeah.
But I will anesthetize that animal for the dental for you.
For sure. Was that, that relationship that they fostered, was it just kind of that culture of learning, or, hey, make mistakes, or mistakes are going to happen, but we're here to learn, or was it a professionalism, or what was it?
It was a little bit of everything combined together, but where at least for me, learning on the floor, if I'm doing something, I'm doing it incorrectly, I need to understand why. And so they would take the time to explain why something wasn't the correct way to do it, or why they preferred a different way. Because there's one thing in anesthesia is that there might be 5 different roads that will take you to the same end result, but what road you take, you have to understand why you're taking that road. And so even though there might be 10 different ways to get to something, you need to understand why you're taking the path that you are. So they would really take the time to explain their reasoning for doing something a certain way, but then they also encouraged us to think for ourselves. And if we did some research and we came up with a different idea, if we could explain that idea to them, they were willing to allow us to try it.
That's
and I
neat.
think that is a huge fostering of, give and take, back and forth. It allowed us to communicate and carry on conversations where we felt like we had a seat at the table and we were actively engaging in the conversation.
That's neat. And like you said, anesthesia, you were scared of in the beginning. I think that's very common for a lot of people inside of that hospital. It's a serious and tense time. That setting, kind of heightens all the
Absolutely. And I think that having a little bit of fear when you do anesthesia makes you stay on your toes. So I think people who think that they know it all and have no issues, they are the ones that can get complacent when they least expect it, and that is when errors happen. So for me, I've been doing anesthesia for 24 years, and I still have a very healthy respect that anything can go wrong at a drop of a hat. So now I have the training, and I continue to learn every single day that I'm doing this, but I have the training to pick something up when it doesn't seem right, and I investigate and I know what to do when things don't seem 100% correct, and I can hopefully jump in and prevent issues from occurring to the point where they start to become a detriment to the patient.
Right. Can you tell us kind of what a typical day in the life for you looks like here at the Tuskegee College of Veterinary Medicine?
Sure. Well, I have a very unique position as a credentialed veterinary technician here. I get the opportunity to do didactic lectures, laboratories, and I'm also on the clinic floor for the 4th years. So if we're talking about a typical day when school is in session, I will be doing clinic cases in the morning, working with the 4th year vet students. It's their job to put together anesthesia protocols, and then we talk about the choices that they made, why they made those choices. We talk about pros and cons of what their decisions are. I'm the one who will check all the math, approve the drug protocols, run it by my clinician to make sure they're happy with it, and then I proceed to draw up the drugs and follow the students through for the entire clinical case. Now, when school is in session, I do have a couple lectures that I do, so all of the lectures for the fall semester happen in the morning. So I might be lecturing at 8 a.m., coming back, doing some clinic cases until about noon, and then if it is a junior surgery day, at noon I go down to junior surgery, and then we start with the junior surgery students. The start of the year, we are doing skills assessments, so they are just getting used to doing all their practicing of the skills that they learned as sophomores in their 2nd year. And once they all feel that they are good to go, there will be an actual skills assessment test that all of the students have to pass in order to gain access to be working on live animals. So that will be the first part of August and September. We will be doing skills assessments, and then the exam will be sometime at the end of September. And then October 1st, we'll start live animal labs for the 3rd year vet students at that time. So for the entire rest of the year, it pretty much goes in that fashion for when school's back in session. So we have labs Tuesday, Wednesday, and then I have some other classes where I might be in lab on Thursday and Friday as well.
Very cool. Another thing you're involved in, of the many things it sounds like, is the Veterinary Anesthesia Nerds Group.
Yes.
Do you mind telling us
Yes.
a little bit about that?
Absolutely. So this was a group that was started, oh my goodness, way back sometime before 2014 by Tasha McNerney, and she was just looking for a way to bring people together with a like-mindedness about one of her favorite topics, anesthesia and analgesia. And so she started this Facebook group, And she quickly realized that there was a lot of interest and that this was something that she could not do on her own. And I had known Tasha for several years. I was one of the people that helped her get her VTS in anesthesia and analgesia, or I talked with her and whatnot. And so I knew her from that standpoint. And then Stephen Seital has been a friend of hers for many, many years. And so she asked the two of us to come on board with and be the three administrators of the group. And before we knew it, we are at over 72,000 members right now for our group. So
is that worldwide?
Yeah, it's worldwide.
Not just
and
US,
it's anybody who has anybody who works in veterinary medicine who has an interest in anesthesia, analgesia, pain management, all of that.
That's
regard.
Awesome.
So, and our goal, our central goal, is to just bring people together to collaborate on the best practices of anesthesia and analgesia. For no matter what type of practice you work in, anesthesia can be run pretty much the same. But what all of us recognize in the veterinary profession is that because there are no standards of care that veterinary practice have to follow, there are a lot of different ways out there that people perform anesthesia. So one of our goals for the page is to educate. So if somebody comes and says, my practice still box down cats, well, we come at it and say, well, let's have a discussion about why that might not be the best option. And so our forum is very education-based. We do a lot of providing evidence-based medicine as far as research papers. We love case discussions because I think that's the best kind of learning, that when we have a case presented, we can really walk through that case, what happened, why we think that happened, where improvements could be made. And a lot of the times we have people come on that post a case that went awesome. And those are just our chance to really help people shine in the moment, where they took the time, they researched the case, they put a lot of effort into it, and they had a positive outcome. And I think celebrating those types of things is also hugely important in this profession.
Great point. There's a lot of reasons when you go to learn something because it didn't go well, and that's tough if that's all you focus on.
Yeah.
And you guys started a podcast, or have had a podcast for some time.
Tasha does the podcast with her lovely husband Rob. He is the IT tech guy behind the scenes doing all that stuff. But so Tasha and Rob kind of do that. So not only do we have the Facebook page, but we also have the website, and then we also do an annual symposium. So we have started that. We've been doing that since 2016. And then, of course, COVID killed us for 2 years, but we just came back. So we had a symposium this year, and it was very successful, and we included a wet lab in it this time.
Nice.
So we partnered with a company called VetBolus, and they kind of did all the logistics part of it, and they let us come in and do all of the teaching aspect of it. So for the last couple of years, we have been partnering with two anesthesiologists, Mike Barletta and Kristen Messenger. So those two and us three, we pretty much put together the CE portion. And then this last April, we added in wet labs, 3 days of wet labs. Wow. So the lectures were in the morning, and then we did a wet lab every day for 3 days.
That's fantastic.
It was a lot of fun. It was a lot of work.
I can imagine.
But a great overall experience. And that's, really, again, our ultimate goal is just education. So as many things as we can do to bring people together to help foster education, the better.
Yeah, well, congratulations.
Thank you.
That's a tremendous amount of popularity, and sounds like you guys have a well-oiled machine and attracting more learners and doers.
Yes,
so
absolutely. We've already got the 2025 symposium on the schedule, and we already have 25 people signed up for it.
Let's go. All right, we'll have to get a copy of that link in our show notes.
Absolutely.
To get some spots from our audience. Okay, Darci, in our part one of our anesthesia discussion on the podcast, we spoke with Sarah and focused more equipment, oriented, because that's, one of our comfort zones with Sarah there and Patterson. With you, we'd like to get more into anesthetic protocol and the drug side and that sort of thing. But before we do, obviously equipment and setting up an anesthetic procedure from the monitor and equipment standpoint is critical. So I'd be just curious to know, how do you guys, set things up for a day of surgery, or any steps or, checks that y'all do?
Sure. So I think This is one of those areas that can get really mundane in anesthesia because we do it all the time. So this is one of the many areas where checklists are hugely and vitally important to ensure that even the simplest, smallest step is not missed. So we utilize checklists to go through that help our students know what breathing circuit to select, what reservoir bag to select, and that's all based on calculations that we do for every individual patient. Once they've got those, they will check to make sure that the oxygen cylinders on the machine are good, because those are our backup. Our E-cylinders are our backup, and then we have a central gas supply that we utilize for the majority of the time. They're tasked with making sure that the vaporizer is full, so here at Tuskegee we use passive scavenging systems, so we have the F-air canisters, so they have to weigh those canisters at the start of their procedure and at the end, and then once they have everything together, they will then pressure check their anesthesia machine. And then we have a monitor that is in the prep room that we use for induction, for pre-med and induction, and then we move our machines into the OR, and there's another monitor that stays in the OR. But our machines, once they're set up, they stay with the patient wherever they go in the hospital.
So an induction area monitor.
Yes.
And then that monitor stays with them as well once they go into surgery?
Well, we have...
Or just the machine?
Yeah, just the machine stays
Yeah.
with the pet, but we have a monitor that stays in the prep room, and then individual monitors at each surgical table back in the ORs.
Okay. Of your students and just in your experience, the checklist is a beautiful idea. Love that. What would be a common mistake or something that's commonly missed on that checklist that you might see or could foresee in a general practice hospital?
Yeah. One of the main things that I hit on even in second year when I first do the anesthesia lectures and labs is how to properly pressure check, because in order to perform a pressure check, you have to close that pop-off valve to get pressure in the system, and you have to occlude the patient end with your finger or the palm of your hand. And so once you do that, it's very easy for people to want to relieve the pressure by just removing your hand from the patient end. And what that ends up doing is reversing the flow of gases in the anesthesia machine. And so some of the machines can actually kick some of the soda lime dust back into the patient side of the
with
circuit.
That burst of air.
Yes.
Okay.
And so
Makes
it's very
sense.
important. And I've actually seen granules come into the inspiratory one-way valve because of that burst of pressure that happens when the flow of gases is reversed.
Okay.
So I am a big harper of to release the pressure after a pressure check, you open the pop-off valve. So not only does that properly release the pressure of the circuit, but it's also ensuring that your pop-off valve is working and then your scavenging system is not occluded. And I can't tell you how many times we've opened that pop-off valve and the reservoir bag doesn't deflate. And that's an immediate indication that something is wrong, and you absolutely don't want to use that machine on a patient. You need to figure out what is going on before proceeding, because that could be a dangerous episode.
Could be
for
an
the patient.
occlusion somewhere.
Yep,
That's the situation.
The pop-off valve isn't working properly, so the valve on the inside of the pop-off valve that we don't see could not be working properly, or your scavenging system is occluded. Like if the F-air canister is put on a flat surface, then that's enough to build up pressure, and so the gases don't have any place to be relieved from. So all of those things are very important to check before actually using the machine on a patient.
Makes sense. I love the pro tip, releasing the pressure from the pop-off valve, basically at the top end, not the bottom.
Absolutely.
Good pro tip, Darci.
Yes.
All right. One of many here. Thank you. That's awesome. Very helpful. Transitioning kind of to the drug side, protocol side, can you describe the importance of providing a balanced anesthesia drug protocol?
Absolutely. So balanced anesthesia is the ability to utilize multiple drugs with different but synergistic mechanisms of action so that we accomplish all the goals of anesthesia, like hypnosis, amnesia, muscle relaxation, analgesia. But we're doing so at such low dosages because of the synergism that we are avoiding the adverse effects that can be associated with using high drug dosages. So we get all the benefit without the adverse effects of the drugs. One huge component to balanced anesthesia is multimodal analgesia. And so with that, we don't just want to focus on one analgesic drug. We want to use a combination of drugs that provide analgesia, again, so that our dosages are kept low, but we're also targeting multiple locations of the pain pathway. So by utilizing multiple drugs with different actions for analgesia, we are giving an overall well-rounded drug protocol, which will ultimately allow us to use less inhalant, which then allows all of our vital parameters to stay normal, and we end up having a nice, smooth anesthesia event rather than one that I would call roller coaster anesthesia.
Chasing
yes,
that
absolutely.
pain and
chasing depth, things like that.
Right.
So if you start with a good balanced protocol of multiple drugs and you covered all of your bases, you can keep the inhalant low from the start, and then all of your vital parameters for the patient are maintained normal. And I really like to stress that the inhalants, out of all of the drugs that we use during anesthesia, the inhalants are the agents that are going to cause the most cardiovascular and respiratory depression.
That's their job.
Yes.
Right.
Yeah. Well, yeah. I mean,
for better or worse.
They're like a double-edged sword to me. So, like, we need them because they're the easiest drugs to use for maintenance and to keep the patient unconscious.
Okay, right.
But if you overuse them, you are going to be dealing with so many adverse effects from overuse of the inhalants that, like you said, that's when we turn into roller coaster anesthesia. Oh, they're too deep, we'll turn them up.
Right.
Oh, now they're getting stimulated, so now we have to turn them up. And you just, it turns into a very rocky anesthesia episode. Whereas if you started from the beginning of providing good sedation, good analgesia, good multimodal analgesia, and keep that inhalant low from the start, you smooth everything out. And then if the patient gets stimulated intra-op, that is where it becomes very important to separate out cognitive awareness from nociceptive stimulation. So nociceptive stimulation means that the patient is being stimulated along the nociception pathway, which is essentially pain, but our patients can't consciously perceive pain when they're unconscious. But that pain pathway is still occurring. So if there's surgical stimulation occurring, and let's say our heart rate goes up, our respiratory rate goes up, blood pressure, any one of those three or a combination of those vital parameters can increase, and it might mean that they are being nociceptively stimulated. A lot of times, the first knee-jerk reaction of most people is just to turn up that vaporizer. And what happens is that if it's the nociception that is the cause of those increase in your vital parameters rather than depth, turning up the vaporizer might blunt all your monitored parameters, but it's not treating the actual problem that is occurring. And because nociception occurs even in an unconscious patient, what that means is that once they are conscious, they are going to have a heightened sense of pain awareness once they are in that conscious state. And that is where pain becomes much more difficult to treat if we don't properly address it intra-op. So anytime you have vital parameters that are increasing in surgery, the first thing you should do is assess the depth of your patient. If depth parameters have not changed, for example, you don't have there's no palpebral response in your patient, the eyes are rolled ventral medial, jaw tone is lax, but you had an increase in heart rate or the patient started panting. If depth indicators are good, then the problem is not inadequate depth. The problem is nociceptive stimulation.
Right.
So in that instance, you should be selecting a drug that will provide further analgesia intra-op. A lot of the times we can give those intra-op drugs at micro dosages so that we're getting the beneficial effects, but again, we're not plowing the animal with a huge dose of a drug and then making all the vital parameters plummet out.
Is that always an injection, or sometimes it's also like a pain injection versus a local anesthetic or a...
So local and regional blocks, those should be things that are done before we even start surgery. So that kind of comes into the preemptive analgesia component of it. So if we know that a patient is undergoing a procedure where we can provide and perform a local or regional block with local anesthetics are the only agent that we use that completely blocks the transmission of pain. So the best use of those agents is to get them on board before the pain stimulus occurs. So for example, if we were doing a hind limb orthopedic procedure, you have several options for regional blocks. We could do an epidural. We could do a femoral sciatic block that is ultrasound guided. We could do a sacrococcygeal or a caudal epidural for a perineal procedure. So we have lots of options for different blocks that we can do based on the procedure that's being performed.
Makes sense. You got pain coming on. You don't just put the patient in a deeper anesthetic plane or state. You don't treat that pain.
Exactly.
Well, here's a question. You mentioned the wet lab for the veterinary anesthesia nerds. I've been in this industry a while and watching a lot of procedures, a lot of conversations with vets and techs about drugs that are selected. It's often the default. The most safe drug you can use is the one you're most familiar with. Is a wet lab, and that's a two-way street. That can keep you maybe on old technology or old drug protocol per se, but where does somebody get that?
Right. I think that unfortunately that statement right there is what holds a lot of veterinarians back from doing more current medicine. And if you really take the time to look, the information is out there and it's free. AHA has done a great job of putting out guidelines on anesthesia, on pain management. There's the International Veterinary Academy of Pain Management, the nerds, our Facebook page.
Right.
If there is a document that explains the beneficial components of anesthesia and analgesia, it is out there, and most of the time it is free. So when I hear a veterinarian say, the safest drug is one I'm familiar with, well, if 30 years ago the only drug you were familiar with was butorphanol, we need to have a good conversation, because there are a lot better medications out there now that are better not only for the patient, but also for us working with these patients, especially when we're putting them under painful procedures. So we can do better for our patients, and so that should not deter you from trying to get out there and learn new things.
Great point.
The more you are working with a drug, a technique, anything, the more comfortable you're going to get with it. And that just requires you to make the effort to get out there and actually learn. So, our wet lab, that is one of the primary reasons why we wanted to start doing this wet lab, is to bring people in and actually have them have hands-on learning so that they can see these techniques are not hard. Regional blocks are not hard to learn. A lot of them, for instance, I am most comfortable doing my regional blocks blind because that's how I was trained. Now, how well that block works when you compare it to doing something like ultrasound guided, sure, you can definitely make the case that ultrasound guided is going to be much better at targeting the area, the specific area that you're wanting to provide that local anesthetic. But I'm still doing something by utilizing my blocks, doing it blind. These are all techniques that can be done in general practice. So the type of practice should not deter you from utilizing these blocks. The advanced training to do it ultrasound guided, like we've got our wet lab that we're doing. There are plenty of other operations that are having wet labs for DVMs. You go to any major conference and I guarantee you there's some lab that is working with regional blocks to some capacity. So it's out there. You have to be willing to go out there and find, and then be willing to go to these conferences and learn something new. One of the greatest joys for me as somebody who is teaching the next generation of veterinarians is to have these students go out on their externship sites and then see anesthesia being performed older style, I guess, quote unquote, old school, if you want to call it that term. But, again, these veterinarians, they're doing what they're comfortable with. And so when these practices are allowing vet students to come and do their preceptorships, part of the requirements of their fourth year of vet school, one of the greatest joys I have is that when a student goes to a practice like that and recognizes that something can be done different, but then to be knowledgeable enough and confident enough to take that information that they've learned with me and have a discussion with the DVM, and then have it even go a next step further and having that DVM be willing for that student who came to them for a preceptorship, integrate that change into the practice and then have a positive experience. So I will never forget, I had a student contact me and she's like, I need your help. She's like, I just participated in masking down a Great Dane that took 6 of us to hold this dog down. And the whole time I was making the statement, guys, there's a better way. I know there's a better way. Will you give me the opportunity to have a discussion with you? And that's all she did. She just posed that question to the doctor and said, I'd like to bring the way that I learned in school to your attention, and can we have that conversation? And the DVM was open to it, and so they had a meeting after that event. The student explained everything about why masking is not appropriate, especially for a big dog. She brought all of the negative reasons to light, and then she went a step further and provided, here's what we can do instead. And so she brought the protocols that she knew how to do from being in lab with me and on clinics with me to this practice. And within a day, that doctor had changed
That's
the
awesome.
way that they were doing anesthesia. So they completely got rid of masking all patients down. And for the rest of the time that student was there and on, they have been utilizing proper anesthesia protocols.
That's awesome.
So those are the stories
Yeah.
that I know it can happen. It's going to take an army to get out there and get this information out there to these DVMs, and then to take it a step further and help them see the benefit of putting these protocols into place.
The All Things Veterinary podcast is sponsored by Patterson Veterinary, supplier of products, equipment, software, services, and essentials for your practice. Patterson goes the extra mile to make sure you get what you need quickly, develops ways to help your practice run a little better, and backs it all with legendary customer service. Find All Things Veterinary at pattersonvet.com. Okay, to your point earlier, a lot of the veterinarians I've worked with over the years, it's really refreshing to see those that have that open mind to new grads, new technicians they hire, coming in, hey, you just got out of school, you just got out of training, come in here, we want to learn what you just learned in school. I got out of school 25 years ago. Maybe things have changed. I'm doing some things different, but it's neat when I see that open-mindedness to new protocols that are sometimes scary to try or be open-minded to. Can you elaborate on that or your thoughts on that?
Yeah, absolutely. I think it is hugely important nowadays for students to get a well-rounded education. So in anesthesia, for example, I think I mentioned earlier, there might be 5 different ways to get to the same problem, but what's important is that all those roads are, the why is explained. And so the students, when they go out into practice, they are going to utilize the road that they feel works best in their brain because they understand the why and they know that the end result is going to be the same. So I think new grads, when they're going out and they're looking for employment, they are going to be more willing to go to a practice that has that open-mindedness of, hey, what did you learn in school? Tell me all the new things that are going on, rather than one that comes out and says, well, 30 years ago, butorphanol is what I'm comfortable with, and we're only using butorphanol for surgeries, and if you want to use something else, too bad. Those grads are going to say, okay, thank you very much. I'm going to go find another job. So I think that, again, a healthy collaboration between somebody who's been in practice for 30 plus years and the new grads, if there is collaboration between the information where everybody can come together, including the veterinary support staff, and have a conversation for ultimately what's the best for the patient, then I think not only does the patient benefit, but the workers and everybody in the vet practice is also going to benefit because everybody is working together and everybody is happy because the patients are being well managed and well cared for.
On the veterinary support staff standpoint, what would you recommend for a technician or staff member that sees an opportunity for improvement? How should they go about approaching the clinic or the doctor or the owner or whoever is involved to make a change?
I think that, number one, you have to realize that regardless of what your title is, you do have a voice. But you cannot just come in there, be all loud, and not have the information to back up what you're saying. So it is going to require you to do the research. It's going to require you to find the references and the resources to back up what you're saying, and to also remind yourself that, hey, I might not know exactly what I'm talking about, or maybe there's a different way to put it, and you're going to learn that with the information that you are researching about the topic. So if you want to bring change to your practice, one of the best things that you can do first and foremost is to educate yourself. So there are plenty of free resources out there. You know, the Anesthesia Nerds Facebook page is a free resource. VSPN, Veterinary Support Personnel Network, free network to communicate with like-minded individuals. It is a network of colleagues that are going to provide you with information, but you can't just stop there. Getting the information is one thing. Reading it and understanding it is a completely different thing. You have to make the commitment to truly understand what you are saying, so that when you have that conversation with, for example, a DVM who might not want to do change, you have to be able and knowledgeable enough to present information in a manner that helps them to understand your point. So coming in and just saying, we have to do it this way because this source says so, is not going to change a person's mind. But coming in and saying, hey, I learned this, and this is how we can integrate this in, and here's the pluses and the minuses for doing so. And if we make this change, then we can make this change on the monitor. And if we do this case, and this case have all shown that the patient recovers much more faster and is much more comfortable after the procedure. So can we give this a try? Presenting it in that manner, you have brought to the table a lot more than just the point that you're wanting to change. You are providing the plan in which change can occur. And to me, that's going to help initiate positive change more than just getting upset that change isn't happening in that practice.
Makes sense. And by the way, if you're looking for a side hustle, Darci's school of debate prep and argument making might be a thing. So consider that. Awesome. So, okay, as we kind of transition through a procedure, let's say, do you mind tossing out just a couple of common areas that you see complications arise? I know there's a bunch, but...
Yeah, I think from an anesthesia standpoint, the most critical periods are induction and recovery. Okay. At induction, that is when things can go wrong if you are not monitoring at pre-med, at induction. And then likewise, when the patient is recovering, I see so many people, as soon as that vaporizer is turned off, all monitoring equipment is removed, the anesthesia machine is taken away, and that animal is just left for itself. And I think, in fact, we have studies. The SEPSAF study shows that recovery is the most likely time for dogs, cats, and rabbits to die. And that study is over 20 years old now, and it's still kind of holds true, to be honest with you. And I think it still shows that recovery, because of the way that we recover our patients, is the most critical time for them. So just because the vaporizer is turned off does not mean that we remove all monitoring equipment and walk away from that animal. So monitoring equipment should stay attached until that patient is extubated. And once they are extubated, at that point, based on their level of consciousness, we might keep an ECG on them. We might keep a Doppler probe on them so that we can hear the heart beating. Because just because they're extubated doesn't mean that they have fully recovered and that they are at a space where everything is back to normal. So a full recovery might be an hour after they're extubated. So just because they're extubated doesn't mean that recovery is immediately over. So these patients require constant monitoring and observation in the recovery period. So here at Tuskegee, we instigated, based on the results of the SEPSAF study, that animal is monitored and has vital signs recorded every hour for the first 3 hours after they have extubated. And then based on that 3-hour check, that will determine how frequently we assess them from that point on.
That's awesome. That makes a lot of sense. Transitioning to that recovery period, I've heard you describe in the past different contributors to a rough recovery. Do you mind describing those for us?
Yes. So I feel that there are 3 main causes of a rough recovery. So pain, emergence delirium, and dysphoria. And so pain, obviously, if you don't have good analgesia pre-op, intra-op, once that patient is conscious, because that nociception is still occurring, they're going to have a heightened sense of pain. So if pain wasn't well addressed during the anesthetic event, you're likely going to have to give a lot more analgesic drugs to get them over that heightened pain response and recovery. So first and foremost, if a patient has a rough recovery, you should always rule out pain by giving an additional dose of analgesia. Emergence delirium, more often than not, results from inadequate sedation at the time of recovery. And a lot of the times, it might be impossible to tell the difference between a patient that's waking up painful and a patient that's waking up with emergence delirium. So I always end up giving a dose of analgesia combined with a microdose of sedative agent just to cover both bases. Those are the two most likely causes of a rough recovery. And this is where dexmedetomidine comes to play very nicely. If it's not contraindicated to give the patient, dexmedetomidine offers some sedation and a level of analgesia. So let's say I don't have additional opioid available and my patient wakes up rough. Then I'm going to give a microdose, a 1 microgram per kilo dose of dexmedetomidine IV, and I'm going to see what that does for my patient. More often than not, they're going to calm right down, and it was just the fact that they woke up suddenly, or they might not have had adequate sedation on board that causes them to be vocal, or they might thrash around their legs and whatnot. Most of the time, a rough recovery, if it's due to pain or emergence delirium, a single microdose of Dexmed or acepromazine combined with an opioid is all that you're going to need to handle and treat that rough recovery. The dysphoria is actually, from an anesthesia standpoint, associated with the use of excessively high dosages of opioids in patients that are not very painful. So if you look back at the anesthesia record and you gave an appropriate dosage of drug, and let's say you gave 1 dose of opioid in the pre-med and you've given nothing more, if that patient wakes up rough, the chance that they're dysphoric is slim to none, because you did not give an overabundance of opioids to cause them to be experiencing dysphoria.
Right.
I see a lot of people classify a patient as dysphoric just because they wake up vocal, and the treatment for dysphoria is very different. You still need to rule out pain and emergence delirium first. So you're still going to try to give a bolus of opioid, still a microdose of of a sedative agent, most likely dexmedetomidine. But a truly dysphoric patient is not going to respond to those low microdoses of the drugs. They're going to continue to display this rough behavior. And a key component to a dysphoric patient is that they don't acknowledge that you're even there with them. Whereas a painful patient or one that's experienced emergence delirium, you can talk calmly to them, you can softly and gently restrain them, and they will calm down. A truly dysphoric patient doesn't care at all that you're there. So those initial treatments are either going to fix it, in which case dysphoria is not the problem, or they're not going to do much of anything, or they might last maybe a minute, and then the patient's going to go right back to doing that treatment. A truly dysphoric patient needs to have potential reversal. And so what I would do is initially start with a partial reversal agent like butorphanol. Butorphanol is going to reverse all the mu agonist effects of the agonist opioid, but it's going to allow some kappa analgesia to stay present. So if your patient underwent a painful procedure, that would be the first step that I would take. And then, of course, if you're really in a situation where that does not fix the problem, then you can consider reversal with naloxone. But you do have to be very careful, because reversal with a full or pure antagonist like naloxone is going to reverse everything about the opioid. And in that situation, you could end up with a very painful patient that can also be very difficult to handle if you don't have other means to provide analgesia than the opioids. So I can count on one hand in the last 20 years how often I've had to reverse a patient with naloxone because I thought they were dysphoric. So I caution people to not immediately jump to using naloxone, because it can actually cause a lot more harm than good when we have several other treatment options that you can do before that.
Makes sense. It does seem like that reversal agent may be reached for more often than probably is 100% necessary.
Yeah. And with that, the reversal for dexmedetomidine, do we have time to talk about that?
Yes, please.
Okay. So that, one of the most common things that I see people do is that if they use dexmedetomidine as a pre-med, they initially want to reverse the dexmedetomidine in recovery, because they think if they get rid of the sedative agent, then that patient's going to wake up quicker and they can be on their way. The problem with that is that when you reverse the dexmedetomidine, you greatly increase the risk of emergence delirium happening. So instead of a patient being laterally recumbent and taking 20, 30 minutes to come around and have a nice smooth recovery, they're up in their cage, moving back and forth, smacking their head on the cage doors, on the cage walls. They're up and moving around, which is not good for a surgical incision. So I really caution people to think about why you are reversing the dexmedetomidine. If there's not a medical need to reverse, then ask yourself why you're doing it. If the answer is just because you want to hasten recovery, because your patient's taking too long to recover, then that's a management problem. That means you need to go back and look at the dosage that you used of dexmedetomidine initially and maybe make that adjustment rather than taking away a drug that is providing some beneficial effects, adding that sedation at the time of recovery.
That makes sense. Speaking of recovery, I feel like this may be something that's not discussed enough, but what are your thoughts on, and I have heard you speak on this, so I'd like to hear them. What are your thoughts on premature stimulation of extubation?
Yes, so...
Do we have an acronym for that, by the way? That
no.
feels like that needs an acronym.
Agreed. We should work on that. Maybe we can...
PTE.
There we go. Yeah, so if you stimulate a patient just to get them to extubate, what ends up happening is that, sure, they might wake up enough for you to extubate them, but they're going to fall right back asleep. And so, again, one of the reasons that recovery is such a critical point where animals can die is because we automatically assume that once they're extubated, they're fully recovered and we can be on our way, and that absolutely is not the case. I mean, once a patient is breathing room air, if their CO2 level builds up because they're not breathing, they could very easily become hypoxemic. Right. That hypoxemia is going to lead to respiratory depression that can proceed to respiratory arrest. And very quickly after respiratory arrest, you get cardiac arrest. So I think premature stimulation just for the benefit of getting them extubated can absolutely do more harm than good. And again, this all goes back to if your patients are taking more than 5 to 10 minutes to extubate after an anesthetic event, you need to go back and look at the drugs that you're utilizing for that protocol, taking care to really pay attention to how much inhalant you have on board. If you have dexmedetomidine as a pre-med, your inhalant should automatically be reduced by 50% right from the start. And if you're not doing that, then that means that you are having your patients be too deep during the anesthetic event, and that in and of itself is going to prolong recovery. It's not the anesthesia that is prolonging recovery and extubation, it's the drug protocol and the things that were done pre-op that are the cause of this rough recovery. So you have to go back and evaluate what is the cause of this prolonged recovery and then make some changes to your protocol to see if you can fix those changes. So just to throw as an example, my patients on the protocols that we use, most of my patients extubate within 5 minutes of turning off the inhalant and are sitting sternal from the time that we move them from the surgery table to the gurney to move them back to the ward. So I know it can be done. Right. So anybody who is dealing with a patient that has prolonged recoveries, I really implore you to go back and look at that drug protocol and see where changes can be made there. That's
a great point. And I think if you run into that situation where you are rushing, you're tapping, you're, hey, sweetie, wake up. If that's a routine thing, it may not be the human element. The client's ready to pick up the pet and go. We're ready to close up for the day. We got starting the procedure late. You know, there's the general practice component of the desire to get them ready, but they're not recovered till they're recovered. Exactly. So if you see this often or more often than you think is just a one-off, then it might be a protocol thing.
Absolutely.
Darci, this has been a phenomenal discussion. As we wrap up, you've mentioned a couple really great resources that folks can go if they have an interest in anesthesia or if they want to continue to learn and advance protocols in their practice. But could you also just tell us the best place to follow your work and any of the things that you and your teams are are
Sure.
working on?
Sure. I think the number one place you're going to find me is on the Veterinary Anesthesia Nerds Facebook page. So Tasha, Stephen, and I are on there every day,
Awesome.
quite a few times throughout the day. So we're constantly, monitoring posts and making sure that good information is being put out there. That would be number one. I also am an instructor for VSPN, which is kind of the sister company to VIN. So I teach several courses on that platform, which is an online-based platform. And you can become a VSPN member. It is free. It's for veterinary
Awesome.
support staff. And there's a lot of free perks associated with being a member. And then the online CE does have a cost associated with it. But one of the things that VSPN prides themselves in, at least for the clinical CE courses, they are all taught by VTS technicians in a variety of specialty areas. There's several of the VTS Anesthesia and Analgesia members that have courses on VSPN, but they offer courses in just about any other specialty area that you can think of, and all those courses are taught by VTS. So it is a great platform to look at for continuing education in the comfort of your own home, because it's all online. But also remember that we, the Anesthesia Nerds, we do have an annual symposium that we put on. So we already have our conference set for June 2025, and registration is already open for that now as well. So we can put that link in the show notes.
Please, where are you guys going to be this
year?
We are
headed to the East Coast, so we will be in Norfolk, Virginia.
Very nice.
Yeah.
Excellent.
So,
okay. Well, hey, thank you so much for your time today and for coming on the podcast.
Thank you so much for having me. This has been fun.
Excellent. Thank you for listening. Join us for more ideas and inspiration on the next All Things Veterinary podcast.